everyone for coming. This is, I believe, my third time speaking here, and I've gotten a better idea of what things and topics are needed. And so I really wanted to focus this year on what can we do as caregivers, as parents at home that's not typically shown in most cases, in most presentations. So I really wanted to find really a way to show, essentially go over some things that are safe for being able to do at home, as well as being able to provide sample demos. And so what I want to do is leave time at the end for Q&A, so if there's anything specific, I have Miss Lucy here that I can show you some of the techniques on, okay? So as she said, I do have 14 years of experience. It's primarily been in neurological cases, working in some really big trauma hospitals in the Houston area, some really specialized clinics out between Houston and Austin, and ultimately I'm here now with my private practice specifically for complex neurological conditions and even chronic illnesses. So I have a pretty good understanding of not just the injury itself, because of my experience in other things like sports and various other genetic conditions. There's a way that the body responds to stimulus that is very, very effective in those children with brain injury. So really the objectives is to, as a caregiver, as a parent, to make you a lot more confident, find safe and effective ways to continue care at home. There's a lot of other factors that can contribute to maybe having less frequency of therapy, less consistent therapy. And so the reason, again, why I'm doing this now is to show if there's not a therapist in place, whether it's a PT, an OT, an SRP, there's other interventions that you can do on your own that are very safe and effective. So I'm just going to touch a little bit on brain injury impairments, standard home health, PT. I know typically there's a lot more resources and tools for outpatient PT, but I focus on the home because I know in most cases, if depending on the severity of the injury, most kids are locked into being at home versus being able to travel to outpatient therapies. We're going to go over more about benefits of caregiver interventions. I'll do some demoing. If you have questions during, I don't mind if you stick your hand up and ask a question. We can kind of flow through. Same thing with stretching, position, and neuromuscular training. So those are the three big topics that I'm going to cover: is ways to position a child, ways to stretch a child, and ways to begin some sort of being at the at-home PT. So common impairments, it also depends on how many years post-injury. A lot of times it's immediately afterwards, but between contracture, spasticity, flaccidity, always comes with other secondary issues related to heart rate issues, blood pressure issues, digestive issues. So we have to consider that when we're thinking about therapy. It's not just, okay, I want my child to sit. Well, how is the inability to sit affecting the way my child is voiding or passing bowels? So typically what happens with home health, I've worked home health for many years contract-wise, and I can get an idea of how much time is really spent. Obviously with documentation, it does limit the amount of time that's actually spent with the child, and it's not the fault of the therapist, it's kind of the way the system is set up. And when we think about, in most cases, most children are receiving home health physical therapy. So with the limitations with the length of time that can actually be spent, so the person's going to really focus in on the child's needs for that time period, and oftentimes it doesn't allow to take extra time to teach a caregiver how to do specific techniques because the time is dedicated to the child. In addition to that, because there's limitations with tools, like you would find in an outpatient facility, the therapist is really trying to zone in on figure out, okay, what can we do with exercises in that moment, but maximize the time that they have within the 30 to 45 minutes. Also understanding skill set is very, very important, just like anything else. If you go to a knee doctor, but the doctor specializes in back, it's not gonna do you any good. So you have to start thinking about being a little bit more selective. And obviously in most cases, those in pediatric focused home health are pediatric trained, so it's good, but there's other home health services that do a combo. So getting an idea what their skill set is and how that's gonna transfer over into your child's therapy. With the total sessions, It typically depends on what kind of insurance. Great insurances provide a lot more, but typically 2 to 3 times a week. My experience is that usually two, depending on, like I said, depending on the insurance. And so what that does too is that if you're limited with the total sessions, there also may be a limitation with the availability of the PT. So again, if they travel, things that typically happen in a workplace. And understanding that the session outcomes can also be dependent on whether or not the child is feeling well, whether it's other comorbidity, secondary diagnosis, or even that moment where there might be, for an example, a UTI, and that may limit. So how can we get over these barriers without completely stopping therapy, so to speak, at home? So the benefits of at-home interventions. And I think the number one thing that I've seen throughout the years that a lot of times parents and caregivers feel like they're going to hurt the child if they do something incorrectly. And yes, there are certain techniques that require specialized physical therapy to actually perform, but there's general techniques that you would typically do on your own that's still considered therapeutic. So by being able to do at-home interventions, this also gives the confidence of not only handling the patient, but being able to advance more with certain activities that you and your therapist are discussing. In addition, it improves muscle activation and nerve functioning. And the big word that everyone's using is a neuroplasticity, right? The more information you give the brain, the more it changes, the more it's plastic, and that requires a lot more time. So if you're thinking about the time that you have with the PT, with the child, if it's twice a week, that's not really a lot of time when you think about all the hours that are spent when the child's by himself. And by being able to do at-home interventions, you're getting a daily dose of information that's going to maximize the amount of neuroplasticity, amount of information, amount of stimulus that this child is receiving, getting much better and faster results versus just only having a few times a week. Again, with the increasing functional outcomes, and this also there's not really much of a differentiation between a new injury and an old injury. And I say not much because you can still get gains even if it's 8, 10 years, 15 years post. The brain is still plastic. Now, obviously, when it's newer, the body's a little bit more receptive to information. So yes, you might get a little bit more than if you wait 10 years, but just know that in other cases that when it's more chronic, you can still get really good results with more consistency. Let me see here. When we talk about the repetitions during the week, and I always tell patients this is that, okay, there's twice a week. When you really think about it, that's 8 times a month. And when you put that in the days in a month, you're technically only getting services for a week and 1 day when you think about how many sessions, right? And there's 3 weeks of just empty that could be utilized at home as a way to really maximize what the PT is doing at home. And so when we start to look at that, in addition to what we think with increase in nerve activation, increase in information to the brain, we look at, okay, now this is a way to reduce risk of contracture, so any stiffness or any locked muscles or tissue. We get into reducing the risk of scoliosis, and it's common with brain injuries because they're not on their feet as often, they start to develop certain sitting patterns that start to change the way the spine is aligned. And also reducing hypersensitivities. It's not uncommon, and most people with children that experience a traumatic brain injury, loud noises, bright lights, and it can cause a startle response, a withdrawal response. And so being able to address these early on and consistently will help better progress, not just from a mobility standpoint, but just being out in the community and just being around in different environments. Okay, so positioning techniques. So this is the first part, and up top I have flaccidity, scoliosis, and spasticity. So what that looks like is someone who has more tone. Are they more rigid? Are they more likely to get either flexor tone or extensor tone? And that being said, if you're not familiar with the extensor tone, if the legs are straight and kind of turn in, the arms turn in, or more of a curled and the knees bent. And that can really take over a lot of functional inabilities to perform dressing, whether it's to perform feeding. And so when we look at positioning, what's a way that we can position a child that will allow for, one, either a passive stretch, or two, allow them to get in a position that's comfortable without them fighting against their own muscles from a spasticity standpoint. Now, when you think about flaccidity or just poor trunk control where, if they're sitting and they don't have enough muscle activation to hold themselves upright, Again, there's other positioning techniques as well that you can do to help re-engage those muscles or to stretch out muscles that might be essentially like tight. So if you have a child, and for an example, Lucy's here sitting in a chair. I have back support. That's my back support to maintain her upright. Even if she has nothing, I have a way to keep her there in a position to keep the spine where it needs to be, whether I'm using pillow props, chest straps. There's various things that you can use, but this is where positioning gets important, because whether the child is more flaccid, more spastic, and beginning to get scoliosis, there's different ways that you can do this without using a lot of time that you may not have during the day, depending on if you're working or if you're busy with other things. So when we think about stretching, we think about, okay, well, if I'm going to hold this stretch for X amount of time, let me hold this for 3 minutes, but I don't have the 3 minutes to stretch the arm because I have to cook. If you set them in positions that do more of a sustained passive stretch, then it's a way for you to get that in one. So I'll be covering that next, but understanding positioning and using props and using towels is going to be really, really important to maintain posture alignment, nerve activation, and also with gastrointestinal functioning. So the more upright you are, the easier bowel's able to pass. The more you're on your back, the more things tend to slow down. And we can use different positions, whether it's you're on your back, you're on your stomach, sitting, sideline, using supportive systems like I mentioned before, whether they're high chair, frames, chest straps, pads. And I'll show you here shortly how to go ahead and start placing some of these pads. Okay, stretching. So the idea behind stretching when we think about, okay, if I'm going to be stretching for 20 minutes for 1 day a week, maybe I'll do it twice a week. The amount of carryover that's really going to happen with that twice may not be as fast if you're doing it for 3 minutes, but every single day. The brain processes information when things are more consistent, whether you stretch, whether you activate the muscle. And when we think about this, they're less likely to get back into these positions, whether they're in a flexor position and you're able to gradually get them from here to here versus trying to force here, but that resistance causes another stress response and also gets them back into this position. So when you think about stretching versus a child who has a little bit more spasticity and a child who doesn't have as much spasticity, you have to keep this in mind. And these are usually techniques that are given by therapists, but oftentimes not always educated. So spasticity is more velocity dependent. So if I move the arm quick, it's going to cause that either the rigidity or the spastic movement. So understanding that slow, passive movements are going to be more beneficial when you're trying to stretch. If you have, if the child has clothes on that are too tight, it can also cause more of a spastic activity that results in just either whole body tone or just inability to stretch out that muscle versus something that's more with like loose clothing. If there's oral medication that's involved as well, making sure that that's taken beforehand before the stretching is occurred, maybe like an hour afterwards. So there's different ways to look at how to begin the stretching to maximize that activity versus trying to fight the muscle, whether they're having contractions or spasticity. Now, when it comes to children with lower tone, you have to think about subluxations and dislocations. And so what that means is when the joint either slightly comes out of the socket or it comes completely out of the socket, meaning that joint went too far. So the same approach is still there with being able to stretch the arm, but understanding the range of motion with your PT. Again, these are things that you're always going to want to be able to discuss with the PT because they're able to give you the guidelines on whether or not this child is at risk for a subluxation or if they already have a current subluxation. And the common areas for subluxation are going to be the shoulder and the hips. So when we get into stretching, like I mentioned before with the positioning, and I'm going to use Lucy here for more a few examples. If she was more spastic into flexion, so where the knees are up, and regardless if you have it on the back, the knees are up, you won't be able to break that position. Now the position you can also use is on the stomach, because once you have on the stomach, the gravity helps stretch out that position and then relax the legs. Also, you can do it on the side, but you're thinking, okay, well, if my child doesn't have the ability to put the head up, or if there's other, maybe some tubes or devices that might be there, then there's other props, and this is when we get into positioning. And granted, I didn't have towels small enough, or pillows small enough for her, so I had to get a bunch of towels. But really what we're looking for in positions again, just using this example, if her knees were more upright and I wanted to stretch more of the hips, you can start beginning to prop in ways that allow, one, for her to get into the position with a lighter version of stretching. So if you can see to the side, there's not really much of a stretch on the hip right now. But as I start removing props or positions, I'm still, from a safety standpoint, being able to block the chest and keeping the mouth, the airway open, and allow gravity to gradually stretch this position. If I wanted to change this into basically a stretching position, I could actively, and keep in mind too, if there's no head control, then yes, the person here would have to be holding the head. There's a lot of things that are related to that. But if the child has head control and we're just applying just light resistance here, now the child is able to get the stretch, and now we can start adding other things that I'll go over next, which is forms of neurological stimulation, whether it's lights and videos. And so you're starting to get into positions that are doing multiple things at once, and you're not needing to spend a ton of time. In the situation that Lucy here has more of an extensor tone, so the legs go completely straight, and you're trying to figure this out. There's positions here where I would go more on the side and find ways, whether it's props between the legs to help bend the leg once the leg has relaxed a little bit, finding ways to prop the arms here just to make sure they're not curling all the way in if there's a little bit more flexor tone. So it doesn't really take a lot of thought when you start thinking about positioning and stretching, because all you're really doing is opposing the direction of whatever that motion is. And as you start to advance more with stretching and positioning, even if it's simply she's on her back, and what typically happens with the extensor tone, the head will go back and the trunk will pop up. Well, once you start to break one pattern of that extension, the body will start to react differently. So if I find a way to make sure that her head is more bent after, again, not fighting the resistance, when she's able to relax and keep her here, that will break some of the tone on the lower half. So now my positioning, all I had to do was really for the legs, and I could even put something underneath the knees to help her get more of a knee bending kind of moment. And it doesn't require a lot of skill to do that. So when you're thinking about initially, whether it's early on or later, what are passive ways that I can position and stretch without dedicating a ton of time based on a normal family schedule? These are really good ways to do that, because then after therapy or in between sessions, if you notice that this person was working on certain techniques to get their arms to move, but the problem was that they were going too much into extension, you can actually help the PT out now by being able to help position and stretch in ways that way they have better outcomes on their end. And then when we look at other supported systems, I'm using towels here, but there's a lot of things that you can use, whether it's with bracing, whether it's with splinting, sometimes casting. Casting you'll find a little bit more in the hospital, but sometimes home health companies will do so. Pillows, wedges, a lot of the things that you can get on Amazon. I mean, not a lot of it is too costly. It's just making sure that you have the right information before you do so. And now we'll get more into the neuromuscular training. So I'm going to revert back to positioning as well as neuromuscular training, because all this kind of goes together. So the idea is, what information can we send to the body that allows the body to react in a way that, one, it's understanding and getting more information to the brain. It's getting a lot more awareness of what it is that's going on. And then we have to figure out, how is this going to be important from a functional standpoint? So whether it's supported or unsupported, again, I know sometimes resources and finances can limit what things that you need to use, but you can use anything at home to recreate the same kind of thing. So what I like to do in these cases is show more of positions that are common for kids to be in just at home on a regular basis. So the first thing is when the child is just simply just sitting on your lap, okay? If this position completely pressed up against me is supported, I now have them working on head control. I may have their feet touching, so they're getting weight bearing on their feet, or maybe I'm even just holding her hand. I'm finding different ways to stimulate what appears to be a simple position, but there's a lot of things that you can do that really, really speed up the process of what the child is getting from that information. Say your child has a little bit more trunk control, but maybe has occurrences where they lose their balance. Okay, maybe I change from supported, now I'm going more unsupported. And so this child has the ability to work a little bit here, but I have full control of the child. Now what happens is a lot of people try to stabilize here, and you never really want to do that. At any point, as long as you have control of the rib cage or the hip, the child will never fall out. It's just either it's going to fold over, and especially if you have the rib cage, it really can't go anywhere. So these are hand techniques that are really useful, even if you need to pick the child up. If you're able to come here versus here, and no, obviously no one would really pull the kids up by the arms, but I've seen it before in other situations. So in this position, now I'm looking, okay, say Lucy has really bad scoliosis, so she's a little bit more curved. Now I'm able to use maybe a forearm on the rib cage, hand here at the bottom. And again, the expectation is, as a parent and caregiver, not to know these techniques, but it's to be able to communicate with your therapist on ways to find these positions so you can carry over at home. So if sitting is an issue and Lucy keeps falling to the left and we really want to stabilize the right side of her body, I want to make sure that I'm setting her up for success by being able to either stretch that position or reintegrate that position that she needs to understand. And again, it doesn't take a lot of effort from you as a parent from a physical standpoint to maintain these positions. If we're thinking about transitions, whether it's into crawling or pulling up to stand, and again, in most cases, those skills are pretty advanced with those with brain injuries, but you can still utilize these positions as a way to really get a lot of muscle activation, a lot of muscle stretch. So if I'm in a position here where Lucy has tighter hips, maybe she doesn't have as much head control, the arms tend to curl in here, and so what I'm trying to do is open her up and open the hips up. Whether you're using toys, whether you're using shows, some other sort of distraction. I'll just do this here. I'll show you from the front, then I'll turn it around. But if I have her, again, on the knees, and this is great for those who have extensor tone, where the leg shoots completely straight. This is a great way to stretch out the knees, assuming that you can get passively, after the spasticity has gone down, into 90 degrees of flexion. In most cases, you're probably going to get closer to 50 degrees or so, and you can still modify it. So if I'm here from the side, and I can position her here, I've now opened the chest up by holding here. I have a good grasp on her. She's not at really any risk for injury because I have her set in a position that's safe. And then I can allow her to bear weight, get information, stabilize the spine, get information to the hips. There's a lot of different things that this carries over into where they choose to stand, whether they transition from here to sitting. There's a lot of movements like that. But I think most importantly, it forces the muscles to activate, and it also forces the body to stretch out a little bit more to maintain that position. If we're thinking about other positions related to crawling and rolling, and maybe the child has more stability going forward but has a tendency to flop the head backwards, we can find other ways to get here where we have Lucy here on her stomach, but we have this so propped up that when she's bearing any weight on her elbows, it's very minimal because most of that pressure is going to be on the pads. But if she's here, I can find a way to support, and even this position being able to focus on head control, arms, and even with a little bit of pressure with the knees, it'll get a little bit of a trunk activation. So being able to combine the neurological training with positioning and stretching, a lot of it is kind of in the same ballpark. It's how you view the position. But thinking about that, if I have one position that I can do multiple things, like I said in the beginning, it's going to make you feel a lot more comfortable. It's going to make the child get a lot more awareness of different positions that are functional, and then allows her body to have more repetitions of constant stimulus that's going to allow her to progress a lot faster. Now, with these positions, obviously we want to make sure that the kids are entertained, and so making it fun is key. Whether, depending on the age, if there were shows that they used to love, whether it's colors, whether it's games and noises, using those things to engage is a big part of getting them to want to be in these positions, and honestly being able to tolerate these positions. Because sometimes if it's new to them, they might be fearful and actually reject that position in a way. So when we talk about visual tracking, and this is a big one that I stress, is because of issues with torticollis or tightening of the neck and the neck getting stuck, and maybe if they're having some sort of neglect and they don't tend to look to the left side, being able to train individually where you're holding lights and seeing if they can track it or if they can focus on it. If you can get certain noises and getting them to respond with a head turn, those are all writing reactions. And being able to force use, or what they call force use, of making them do the actual task but making it fun, but understanding that it shouldn't be too loud. You have to start off with lower tones and softer colors before going to bright, because the reality is that these kids are going to go out in the community and they're going to see louder, brighter signs. They're going to hear louder noises, and so we want to gradually dose, or something that they call habituation that we typically use for vestibular rehab, is giving small doses and letting the brain get used to that dose and then gradually getting more, so it's not such an abrupt stimulus to them. So this is also a great way to desensitize them, and I know this is also big with loud noises, or someone slams the door and they startle, is finding different ways. Maybe you're closing the door a little bit softer, maybe a little bit louder, and those repetitions, although you're not working directly with the child, you're able to still do the stimulus without being directly with the child in that moment. And so what I'm going to do, I'm going to go over, or kind of leave it open-ended for some positional, stretching, neurological questions before I go into this ending part, just because it's a little bit more specific of understanding what to look for in PTs, how to communicate with the PTs, and getting really someone who's going to fully collaborate, not just with the PT itself, because we can't do it by ourselves without the SLPs or the OTs, because there's different parts that we're all working on to achieve the same goal. So is there any questions specifically on the positioning, whether it's with props, the age of your child? This is going to vary. I have obviously Lucy's just a little baby, but there's kids that are like 12 years old, and so they may have different responses to them versus what Lucy's age would be. Yes? Yes. No, well, okay, so my question is, when he's on his stomach, what activities is he doing? Okay. Okay. Does he have any contractures, any other things related? Okay. So you can kind of use it more so with the being positioned on the stomach is not a bad thing, but we want to combine it with things that are productive in that position. So if he's watching TV, is he propping on his elbows? Is he changing anything there? That would be a good way to start propping with. If he doesn't feel as comfortable, being able to prop it under his chest to let him know, okay, my elbows, it's a little bit weirder to touch the ground, so I'm going to have to use them a little bit if I really want to see. If he's watching TV, are you the one controlling it? Is there a way that you can set the screen a little bit higher to get him more posture? So now you're getting thoracic extension, neck extension. So there's various ways that you can use the position that he likes for that. But then also, okay, that part is going to be addressed with the stomach position, but how about you transition it? You can even try the all fours position. Can you break some extensor tone there? But I usually try to build the trust with a kid, because they are a lot smarter than we think they are, and so them being able to trust that position and gradually go up into those positions, and you can even alternate, make it a game. But I think that would be a great way to break some extensor tone while he's in that stomach position. Mm-hmm. Anyone else? Yes. Mhm. Uh-huh. Mhm. So are you saying that that muscle is staying bent? Okay. Have they ever prescribed whether it's any splints, night braces, anything like that to maintain? Okay. Hmm. Yeah, so especially with like startle reflexes, excitement, that's going to cause that quick jolt. Um, but I know they have different kind of braces now, and so this is a good way to start talking about splints. Is that a lot of time they have fixed joints where I'll use an AFO as an example for the ankle. It's fixed, and it just stays that way. They have different arm splints that actually it's like a little, almost like a little crank. So like every 2 weeks you're moving it 2 degrees or something like that. So it's a longer passive stretch, but you're gradually making smaller increments. But to get from here to here, if someone has spasticity, is it's going to take a bit because you have to think about the lining over the muscle, like the fascia is getting so tight because it's consistently in that position. So that is one tool that can be used. And another is depending on, again, with positioning. So if my arms are this way, what's a way to even get it into a prop? So now he's not going to want to curl if he has to hold himself up, because then his face is going to be on the ground. So I don't know how much tone he has in the other arms in position. So for an example, if I guess you can kind of see if his arms were here, then if I even start pillowing to where the arm isn't coming in, maybe it's bending, but it's not coming in toward the chest, I start there. And then once I get a little bit more consistency there, then you could even prop to where, depending on what, if they're lying on their side, you can even do passive. You can find ways, whether if you're using the brace, you're not using the brace, to splinting ways from a pillow standpoint that doesn't allow the arm to bend. So if, in this case, if I want to stop this, I can't bend anymore because I have a soft fabric. Now, this isn't going to cause any skin issues. Again, assuming that this isn't for like 8 hours, so then you have to like do skin checks. But finding things that you can place in there, and as his body relaxes more, then it should. The thing is, if there's something that's constantly he's fighting, that's going to be the trick because that's going to cause more of that spasticity response. So it also depends too if how long it's going on. I don't know if there's developed any contractures at that point, so maybe he can only get to a little bit past, a little less than 90 degrees, maybe 70 degrees of elbow flexion, but then at that point there's a contracture. That would be something that would be checked from a medical standpoint, but utilizing different tools like that consistently is what I've seen help in that situation, especially with arms. It is a much longer process maintaining range of motion in an arm than it is a leg. Um, any other questions? Yes. Yeah. I so are you thinking about someone in particular, or are you thinking just in general with patients? Okay. Um, I feel like there's a few options. One, if there's external frames, and I don't know, I mean, I'm using a standing frame as an example because they have a shin pad that doesn't allow you to kick out. Um, Even if positioning, I know there's been times where I've put items on the wall and sat them close enough to the wall to their feet are actually touching so they can't actually kick any further than that, but they can't push themselves back because I already have their back as close as to here, so that's about the extent of they're going to get. And I'm just referring to in a sitting position. When it comes to, let's say, on their stomach in an all fours position, would he be able to put his hands down? He just wants to kick his legs out. That typically would happen. Okay. So then what I've also done too is, I'll just get on here. I've put those exercise balls, and again, finding a size that's relative to his size, not overly big, but If this is the wall here, I will actually put the ball against the wall. I'll have them, their bottom is touching, so they can't push any further back. They'll feel a little bit of a push, but now they're here, so they can't really kick back because both the ball and the wall are blocking them from that position. So that's another creative way to block it because they can't. The only thing that will happen if they don't want to do it, they'll just come down. But it will limit that position. And these are the things that, I mean, these are great questions because not a lot of people were like, oh, I would never would have thought to put a ball against the wall and have the hips. That all your PTs should have some knowledge and creativity on being able to modify these kind of positions, even by using some sort of wedge or block. The positioning part takes time, but once you realize you have to go away from the position that's most sensitive to your child. So you have to kind of go almost backwards. You have to gradually build that up and find ways because the association with them not wanting to do the things they don't like will be associated with other things if it's always that same thing that they don't enjoy. So you have to kind of break the skill down a little bit more. But those are a few options that you can start off with. Sitting, I think, is a better option because it's more upright, it's more stimulating versus being on your, all fours or on your stomach. Yes?
The hand's always in fist position when it comes in, or like similar to this. She relaxed when she tried to. It's got reflection.
Oh, it's almost like a remesis phenomenon where you use one side to get activation on the other side. Yeah.
That's what she thinks.
But also, too, that kind of goes back into the specializations. What I was referring to earlier is the people who've had a little bit more experience. It's not saying a PT who doesn't have that specialty is a bad PT. It's just when it's something, there's various conditions with pediatric home health, and not all of it is brain injury, right? So someone who has more experience with that is going to be more useful because then they're able to understand, okay, if that is actually a form of training where you activate the other side to get activation here, but then there's other steps that you need to take to maintain the activation on this side. Mhm. 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 And those are even techniques that style of treatment are also things that you can do at home that doesn't require another therapist to do, given that you have the correct instructions and those kind of things. So that's a perfect example of um, why at-home interventions are so beneficial because that kind of a presentation requires a daily dose of the same thing over and over to get that brain to cross over and maximize that use on the other side. So again, these are little things that y'all could do. And so going back to the hand, when it's squeezing, if it's stuck there, there's again various things that OTs provide, whether it's a splint, there's hand pieces that you can use, there's certain training that you can do for the shoulder. But on your end, the simplest form is finding ways again to position, even if you don't have anything like a splint. What are you putting in the hand to keep the hand as open as you can? And then you can allow her just to sit. And if she's watching TV or whatever it is, again, you don't always have to be as attentive, but if you know the ways to position and to stretch, you can really utilize the time you have, 2 minutes here, 5 minutes there, 1 minute there. But it goes a long way when it comes to having longer lasting results. Yes. So meaning he's more here. Mhm. So is he not able to hold his head in that position, or does he just rest in that position? And so that would actually be the bigger point to address first before even the neck. Because if that is a daily, okay, so now think about the thumb sucking. Like, what can we do to minimize that actually being exposed? Not so much you're putting them in a glove or anything, but there's certain, whether they have a like a what do you call it? Like the little mittens. I've seen people use that. Yeah, and it's still has he done speech? Any oral sensitivity things? Hmm. How old is he? Two. Okay. Um, have there been any other devices that would replicate what would be a thumb that you can put in his opposite hand that would draw him only to his opposite hand? Okay, interesting. Um, that I would say that there are. How long had you been doing therapy for? Year and a half. Okay. There are. I've seen a few cases of that, and there's just different. Mhm. And that I'm wondering too, because it's from a desensitization, both from orally and from the hand, what that would look like. So there's even techniques that you can do at home, whether it's, and I'm giving you the basic because there are more advanced, but if there's like light scrubbing with firm and light and prickled and a lot of things that help him understand different kind of feels and what sensory is what sensation is what, in addition to what is on that thumb, is there anything that's ever been done around the thumb, not so much just in the mouth, but around the hand? Because we have so many superficial nerves in the hand that allow us to feel so much. It's like, okay, what's a way to desensitize the hand, whether it's from an OT standpoint, from a PT standpoint, a speech standpoint, but that would be where my head would go first. But again, because the child is constantly growing, also timelines might be a little bit longer. So it's almost like not so much you have to wait, but you kind of do because they're going to develop different habits and they're going to see new things and develop a different habit. And so understanding that, but being consistent will be the thing that will help. An example, I was working with a child who wouldn't walk and he just would not put his feet on the ground at all. You pick him up, you put him on the ground, he lifts his feet up. Took, I think, 11 months until finally we did a different approach of desensitizing him, doing things that were completely opposite of just standing, of just what he felt. And it was within like 2 months that he actually started to kind of tap his foot. And so you're constantly changing, but with the PT, that's the stuff that they need to be giving you at home, specific to like, okay, what can I do on my own? Like, okay, yes, if I put a mitt or I put something in the other hand, I'm gonna work on that 3 minutes a day, every single day until, whatever plan that they have kind of thing. So again, the at-home part is what I think is going to be beneficial for you in that case, because I think there's got to be a bit of a different approach of just trying to put things to look. I feel like it's more than that. I feel like there's something from a sensory standpoint that can also cause that. I'll take one more question, then I'll start to wrap up a little bit. Everyone good? Okay. So going along the lines of what I was going to end with is, with any sort of brain injury, TBI, noxic brain injury, there's so much that's required, a lot of patience, a lot of teaching, a lot of education. And with that type of need, you're going to need someone who's passionate, someone who's very creative, someone who's open with collaborating with different providers, even hearing from the same provider in the same discipline. I put some credentials here that they're just more advanced neurological training, whether it's an NDT, PNF. Schroth method is really good for a lot of scoliosis, and they're really good at adapting active training, but also passive training that you can do at home. And I believe there's someone speaking tomorrow about that, if you catch her. Her name is Danielle. And then everything is communicating. I mean, that example with the thumb sucking, really talking with OT and speech is going to be super, super important, and figure out what's the best way that y'all can work as a group to figure out what it is that needs to happen, even if it's outside the box. Okay, summary. After 14 years of working, I know the difference between, and this really would be the same for anything else, whether it's health and wellness. If you're working out 3 to 4 times a week, physically, aesthetically, you're going to feel a lot different than if you're working out once a week, maybe twice a week. It's not as consistent. The same thing is happening for these kids. So to maximize results, don't feel like you have to spend 20, 30 minutes, an hour a day. It's really not that much time that you need. There's a lot of new research that says that you only need about 3 to 6 repetitions of one thing consistently to actually remember the skill. So thinking about from a time standpoint, if you get in the habit of doing these little things that it's just small doses, that's going to go a long way in maximizing the results of your child. Being able to handle Miss Lucy over here in a bunch of different positions does strengthen and give you confidence in your ability to handle your child, even if something else were to happen. You know how to handle the child. You know, you're familiar with its responses when they're on their belly, or on their back, or on their side. And I think it goes a long way too when you're able to identify that if something's going on, you're able to address it pretty quick. Reducing the risk of further medical complications, typically fresh on some sort of head trauma, is a lot of GI, a lot of heart rate, and a lot of breathing issues. So by being consistent will also reduce the risk of these things occurring in the future, whether it's pneumonias and cardiac arrest, those kind of things. There's a lot of different things that can happen due to brain trauma. And then working with the PT, I mean, most PTs are pretty open and just say, hey, I know you don't have a lot of time, but why don't we talk about spending a day where maybe half the time is dedicated to my child and half the time is really teaching me something I can do for the week. And maybe you're just doing it once a month. I mean, that just training with them once a month and giving you new stuff makes you feel like you're also progressing too as a caregiver. And just a little bit about what we do, I just try to give a little bit of explanation. I've been doing a lot of caregiver training virtually, whether it's in the States or overseas. It's something, even on site, I've had the pleasure to work with a lot of people at this conference, and it's just really giving you the basis of showing you what it feels like, what to do, what not to do. And so if anyone is interested in that, even just having a conversation of just questions like you were asking, I'd be happy just to give you some tips on that. And everything we do, I'm here in Austin. We have it in Houston and Austin, and so we do on-site training as well, and we do virtuals. And then I have a discount for all virtuals, anyone from here. Any questions, get with Rhonda. There's also ways that Team Luke is working with me on this. Been working with Team Luke for about 5 years now, so if you have any questions on that, let me know. And then all the stuff, all the ways to reach out, whether it's the websites, the social medias, and all those things. If you have any questions, please let me know. But thank you for your time, and I appreciate everyone joining. Let me know if you have any questions.